Welcome to another CME session from SJMC. We hope you enjoy the content.
To another Saturday grand rounds from Subang Jaya Medical Center. I'm Alute with my colleagues, Dr. Ng Soo Chin and Dr. Haris Abdul Rahman. And just some housekeeping slides. You see in this slide that our topic for discussion today is conquering iron deficiency anemia, and we're focusing on harnessing the strength of IV therapy. So we've got a couple of cases which I hope will interest you all. And just to make a note that our Q&A will be at the end of the session. So you can join us on Slido. If you're watching in our CME webpage, the Slido is already embedded at the bottom, and you can ask your questions there, or you can scan this QR code to go to slido.com, or if you already have the Slido app, you can enter 1441888 to join us in the Q&A. Okay. This session is eligible for a CPD point. And the way you claim the CPD point will be by scanning a QR code for the MMA app, and this code will be displayed at the end of the talk. You can scan, if you're watching on a laptop or desktop or iPad, you can use your phone with the MMA app and scan it the usual way. In case you're not aware, if you're already watching from your mobile phone, you can't do that, but you can take a screenshot and then save it to your album and then scan it on the right here. You can see at the bottom right there is a option to scan from your album. Okay, so you can save a screenshot. Please remind you guys, do not share this QR code to others who have not watched. That's cheating, not very ethical. MMA realizes it is a bit of a small problem, this sharing of QR code, and there will be some measures taken if that happens. So without further ado, I'm going to pass over to Dr. Haris, who will be the moderator for the session. So over to you, Dr. Haris.
Thank you very much, Dr. Allen. It certainly is a pleasure to actually be one of the speakers for the session, and it's an honor to be with yourself, Dr. Allen, and also Dr. Ng Soo Chin. So I will start by, first of all, giving some overview of the condition on hand. So we had a session about a couple of months back talking about iron deficiency and how sometimes it can catch us by surprise. It turns out that the diagnosis is something else. But there's no trickery in this session. Basically, we want to talk about once the iron deficiency is established, what would be the next step in terms of management and all that. And today we are focusing on one of the newer treatment available, which is intravenous application of iron. So iron deficiency and practice, I'm going to start with, is something that is actually very common. We think that most of the time it's probably been neglected because it was so common, and majority of patients may not actually realize that they have the condition. So it's actually a spectrum. So you start with a normal scenario where the patient actually have normal parameters. And sometimes the early stages of iron deficiency, they may have some fatigue. There's nothing to go by in terms of symptoms. And this is what we term as stage one iron depletion, where only the ferritin started to go down while all the parameters seems to be fine. Then you start to become symptomatic, and at the end of the spectrum, you may actually have very low hemoglobin, low ferritin, low serum iron, and also we're going to talk about some of the other parameters that may help us in establishing the diagnosis and also guide us with treatment. So when we talk about iron deficiency, it certainly is a spectrum, and we sometimes only get the symptoms when we are actually quite deep in the far end. So usually the parameters that we go by would be serum ferritin. 100 is considered normal. Sometimes we do not have any symptoms until it's very low, maybe 30 or 40. We start to have some headache, some discomfort, maybe some hair loss when the level reach about 70. But most of the time, we actually feel a bit off. And sometimes it's quite difficult to actually go by in terms of symptoms alone. So in a normal circumstances, we have a normal plasma iron, normal hemoglobin. And in terms of the regulatory cycle, we actually increase our hepcidin level. So hepcidin actually reduce iron absorption, making sure that we are not overloaded with iron. The the transport molecule for iron, which is ferroprotein, is also stopped and depleted. So we actually control our serum iron that way. So when plasma iron is low, the opposite happens. We reduce our hepcidin level and we start to absorb more iron and release whatever storage that we have in our body to actually increase the plasma iron and start to make blood again. So one of the main regulatory proteins is actually a molecule that's been discovered only recently back in the mid-90s called hepcidin. Hepcidin was first discovered in the liver and it's get released during inflammation. So in normal circumstances, when there is actually a rise in serum iron, we actually raise our serum hepcidin level as well. And by this, it actually reduces our absorption of iron. But unfortunately, hepcidin is also upregulated with inflammation, and that actually is helped by the increase in cytokine. That's probably explain why in circumstances where we have very severe cytokine storm, our ferritin level also get increased. When the hepcidin level is high, we reduce absorption, and also we reduce the buyback mechanism, the recycling mechanism that we have in our body to salvage whatever iron that is really available to go back into the circulation. So the net effect of increased hepcidin is actually reduction of the iron in circulation. So if we have a chronic inflammatory condition where the hepcidin is elevated, not in sync with our iron level, we end up with anemia of chronic disease. So, so we have these two conditions side by side where we have absolute iron deficiency and what we call functional iron deficiency or iron sequestration. So the difference between these two scenarios is the serum iron, the iron store is low and serum iron is low in absolute iron deficiency. But the opposite is actually true in functional iron. Iron store is good, but the serum iron is actually low, and hence we end up with a level of hemoglobin that's low that sometimes can be difficult to actually differentiate between normal iron deficiency because in both scenarios the iron level is low, and we're going to delve into some of the mechanism that we can utilize to actually differentiate between the two. So in normal circumstances we mobilize our iron that's actually saved up in esophagus, kept in the liver, for instance, and this goes into the bone marrow where hemoglobin is produced. In the sequence where um, iron deficiency absolute is quite simple to really explain. There's no iron to go about, hence there's no iron entering the bone marrow, and we end up with reduction in production of hemoglobin. But in functional iron deficiency, there is actually a problem in mobilizing the available iron that we have. And this end up with a normal total iron, uh, the serum iron is low, and also the hemoglobin is low. And to differentiate between these two sometimes can be a bit tricky if we just depend on the level of ferritin as our main guide. So as I mentioned earlier on, if the iron, the ferritin level is less than 30, more likely than not, the patient is actually iron deficient. So that's quite straightforward. But unfortunately, in the presence of inflammation, the ferritin can be driven up by other mechanisms, by interleukin and all that. So this can be misleading. We cannot rely on ferritin alone to actually diagnose our patient with iron deficiency. This is where we utilize the serum, the total transferrin saturation as our guide. So in normal circumstances, if the total transferrin saturation is low, and the ferritin is high, we know that in these circumstances that it's very likely that the patient does not have iron deficiency, but instead they have functional iron deficiency. So, um, transferrin saturation is now starting to become utilized in clinical practice, and certainly it helps to differentiate between these two circumstances that we talked about. So, is it dangerous to have a non-anemic iron deficiency? Well, lately there's been abundance of data to suggest that it is actually a clinical entity, and if not expressed, it does actually impact on our health. This is actually a paper actually published just around the time of the pandemic, where in patient without iron deficiency but has got established iron deficient, doesn't have anemia, but the ferritin is less than 30, there's been over almost 15-year follow-up that the risk to mortality is actually increased by almost half. So there are obviously a multifactorial facet to all this, but with the amount of data that we have, it's actually quite established now that we should take iron deficiency or iron depletion in itself is something that needs addressing. There are many papers available at the moment, some of them associating iron deficiency that as a cause for cancer rather than it being a consequence of cancer in colorectal cancer, for instance. So there are now many papers to suggest that we should be taking low ferritin level as something that is serious that needs addressing. So when you are established that somebody has got or in a low iron state, what options do we have? I mean, first of all, it's always important, and I cannot emphasize this anymore, that there is actually a need to establish why the patient is anemic in the first place, especially when there is actually picture of iron deficiency. Is the patient bleeding? Has the patient got an underlying condition? So sometimes anemia can present itself late in adulthood when the patient actually have thalassemia trait, for instance, or they have ovallocytosis. So this also may be the first hint towards myelodysplasia. So in Malaysia, actually anemia is very, very common, which reminds me of anecdote that I remember when I was with working in University Hospital. We actually have got one of those double whammy is Ramadan and Hungry Ghost Month. So we are not able to get much blood supply in our blood bank. So what we did was we grouped up all the student nurses and staff nurses to actually come to our blood bank and do some screening. Unfortunately, about 70% of them did not qualify because they got some degree of iron depletion. So it's very, very common. There are papers now that I can quote here that establish that in 1 in 3 women in reproductive age actually got anemia. About 1/3 of our adult population, the elderly, actually have some degree of anemia. And it's actually more common among Indian and Malays, maybe because the Chinese like to eat their meat. So Indian do not, for instance, do not eat much meat. Malays would prefer some chicken and possibly seafood. That's probably explain why. And it's not just in ladies. There are actually papers to show that in our country alone, the prevalence of older men with iron deficiency is 3 times the younger population. So overall, it is actually something that's very common, and I'm sure it's actually under is underdiagnosed in our population. So how do we replace iron in this iron depleted individuals? So we have a few options. So these are the common ones. We can actually look into their diet. We can implement iron supplementation. In the extreme cases, we may actually talk about blood transfusion, but there's now a new kid in the block, intravenous iron. Looking at the iron storage first, or our diet first, there are two kinds of iron actually in our diet, which are the ferrous and ferric. F2, which is heme iron, and F3, which is non-heme iron. The absorption mechanism is slightly different. Heme iron is usually readily available in meat products, so as you can see in this graph here, while in a non-heme iron is usually in almonds and apricot. So this, if you want to go down the vegetarian route, at least you can look at apricots and almonds as your main source of iron. But the absorption is slightly different because the ferric iron or non-heme iron, they need to be converted first into heme iron during the absorption process. But paradoxically, during storage time, it's actually gone back to F3, which is ferric iron. But that's a topic for a different discussion. So there are certain diets that actually inhibit the absorption of iron. Is a question that a lot of people ask us. Some of them may be true. Some of them may be a bit of misrepresentation. But the main question that people ask me is, does coffee actually prevent iron absorption? It's actually the other way around. Coffee is not too bad, but tea, that's actually a problem. But then I don't want to actually open a can of worms and start to have a debate on this. But it is actually established in Journal of Nutrition. So when we go to our pharmacy, there's a lot of available supplementation. There are two kinds basically, the ferrous and ferric. The most readily one are all ferrous, but they do have some side effect in the GI. So we tend to, at least myself, tend to actually prescribe more um, ferrous iron, which is one of the main ones called maltopher. So when all else fail, red blood cell transfusion is an option, but we try to avoid them because it's not something that is completely safe if we don't use it judiciously. There's always a risk of transfusion. From one end, you can actually have um, antibody formation, while at the other extreme, transmission of HIV and all that is something I talked about. We want to minimize them, but the main risk are actually somewhere in between, somewhere in the middle there. So transfusion-related febrile episode, trially, circulatory overload is something that we need to actually be more judicious about. And there's always a question of are we actually over giving our iron when we actually give transfusion, because the iron that's actually accumulated by the patient may not be able to be secreted out. And when we look into all those users of iron, we realize that it's only about 5% of transfusion is probably appropriate. So if we look at the data in Malaysia in 1 year, this is actually data from last year, so we're talking about 2021. Almost 750,000 units were transfused then during the pandemic. And if we take 12% appropriate, maybe we're talking about 75,000 units that actually appropriate. So the rest of it is quite controversial. I think we are over using it, but then again, there are circumstances where it's needed. And before I end my talk, let's touch on the meat of our discussion today, which is the iron, intravenous iron. So we look into the pros and cons. If you compare blood to intravenous iron, yes, it's faster to give iron. Some might argue it is safer, yes. It does contain more iron, meaning that you go straight to the spot. So you actually getting the body to actually replete the iron store and start to make blood which are fresh. In terms of cost, because the cost of blood transfusion is not passed to the patient, they did not realize how expensive it can be. So intravenous iron, even though it is actually quoted to be more expensive, But if it's used judiciously, I think in the long run, it's probably going to be for the buck. Heavy iron's been around the block for many years, but the initial part in the 1930s when it's available is painful. It's just pure iron, heavy metal infusion, just sclerose the vein like there's no tomorrow. But over time, there's actually more proof to more research to actually find a safer iron type of infusion. So they come up with an iron shell that actually protects the infusion to the patient. So the modern intravenous iron product actually are based on this principle. So the different parts of the iron that actually given to the patient bypasses the hepcidin molecule. So the patient actually gets straight into the system and do not have to rely on the hepcidin cycle to block the absorption. So the difference between the iron products actually the shell that they actually carry. So in Malaysia at the moment, we have four main products: Cosmofer, Venofer, Pharynjet, and Monofer. We have access to all of them, and there are some subtle difference between them, and the difference mainly on the shell they actually produce. So if you look at the the one that is available for a long time, which is Venofer, is actually given over about an hour, 50 minutes quoted here, but there's a limit on how much you can give. While the newer one, Ferinject, for instance, you can actually give a higher dose at a rate almost similar to Venofer. So there are options for them for our patients to take. And in terms of which one is better than others, it's probably something that we can discuss a bit later on. But I don't think this is the main forum to look into it. I'm sure during the example later on case study, we might be able to touch upon the options that are available. In terms of the indication, they are actually safe to be given in pregnant ladies. And nowadays, there are actually evidence to show that in patients with heart failure and chronic kidney disease, it actually helps in actually reduces inflammation, actually help with the general outcome. In terms of sensitivity, a lot been made about allergic reaction to iron, but in the scheme of things, when you look at the other drugs available in the market, the instances are actually quite low. The newer IV iron actually have less than 0.1% reaction. Mainly the reaction can be actually divided into three, which is isolated symptoms, non-specific like diarrhea, itching, rash, headache, and all that. The most severe one is the anaphylaxis. Unfortunately, this one, if you see one, you have to act immediately and the patient needs to be resuscitated and the infusion stopped. While the others, you can actually re-challenge it. And one of the reaction that we normally heard about, but we'll probably seldom see, we do not actually practice intravenous iron is what we call fishbone reaction. It's actually very common. It's not related to fish. Fishbane is actually the name of this gentleman, Professor Stephen Fishbane, actually a nephrologist in New York. He actually described this reaction where he stopped the infusion for 15 minutes, calmed the patient down, and then we start again without much problem. So once you see and recognize it, it's actually quite safe to continue. It's not an anaphylactic reaction. So the learning points to take before I end this talk is iron deficiency is common in our community, it's underdiagnosed, and as such, it's probably undertreated. Once we establish somebody's got iron deficiency, it's important to actually identify the underlying cause. There are various modalities for replacement, and as far as we can, as far as we're concerned, we try to avoid transfusion as much as possible, and the option of intravenous iron certainly help with us foregoing the transfusion option. So, hope that we can have some more discussion about this later on after the talk. To start off with the next segment, I would like to invite Dr. Ng Soo Chin that will present case for us to enjoy. Dr. Ng.
Okay. Okay. Hello, everybody. I don't think you enjoy the case, but nevertheless, let me present the case. Before I start, I think we should not miss the forest for the trees. So the management of iron deficiency anemia actually consists of three parts. First, we identify the iron deficiency anemia. I think we still have candidates coming for postgraduate exam and asking how you diagnose iron deficiency anemia. They will say serum iron to the bone marrow, and they forget about ferritin. To me, I think this recognize that ferritin remains the most robust definitive test for iron deficiency anemia. Of course, we take into consideration that in inflammatory condition, the ferritin may be raised, but there's still a range that we can work on. So anybody ferritin less than 5 uh, and in a family condition less than 50 is taken to be iron deficiency unless proven otherwise. Now, the one in red, investigation and management of underlying etiology of iron deficiency anemia is actually the single most important part of management when you face with a patient with iron deficiency anemia. Identifying the problem is one, then you must work out what is the underlying etiology, and lastly, the iron depletion, which can be oral or IV, which Dr. Harris has discussed a while ago. Let's move on to the next case, the actual case. This is a 44-year-old Malay lady, graduated as an engineer, but she had been working as a teacher for the longest time. And she's a known case of Gleason disease diagnosed at the age of 12. Her chief complaint on the 8th of January 2023 was rectal bleeding for 2 days. She had rubber banding done a week earlier. Now, the current problem actually started 14 September 2022. So this is about 3-4 months earlier when she had PR bleeding and severe anemia leading to single attack. So she was brought in with an HP of 4.4, ferritin 135.6 nanogram per mil. She was transfused with blood at that time and given Monofer as well, over 500 milligram. Usually I give it a bit longer, can run in supposedly over an hour. We can discuss that in a while. She was also given tranexamic acid to reduce the bleeding. Discharged then, and she was asked to see a surgeon. Unfortunately, she did not avail herself. And on 22nd of December 2022, she again had 2 episodes of bleeding, and again the hemoglobin was so low that she landed up in the intensive care unit, given blood, and this time she was again given the iron infusion Ferijet. You may ask why the different preparation. Well, we got 3 samples at the time, so she was given Ferijet. She was discharged with rubber banding, and the surgeon who attended to her specifically asked her to have a GI endoscopy done. But unfortunately, she again kind of defaulted, and hence the latest admission in January. Single bit part of a little bit of the past history as well obstetric. She during a time of delivery, she need platelet transfusion. Interestingly, a family history, the sister also had a Gleason disease. She's a non-smoker and non-drinker. Her hemorrhoid is only a recent problem. Now, physical examination unremarkable except for the marked pallor. And if you look at the hemoglobin chart, she was actually trending quite okay until the recent 2 episodes when it dropped very low, as low as 3 and 4. Now, finally, the third time we managed to persuade her to, to get a GI assessment, and unfortunately, the colonoscopy shows an obstructive mass at 40 cm, and the CT shows a luminal mass. She underwent an anterior resection. And again, sadly, she had actually moderately differentiated adenosine as tube C because the nodes are involved. So we refer to IKN oncology unit, but again, she did not proceed on to adjuvant chemotherapy that was suggested. And lately, the last I heard is she came to the hospital with lower abdominal pain, and there were mass suggestive of Kugelberg tumor. She was referred back to IKN again. Now, summarize the case. This is a young lady with Glanzmann's disease, history of menorrhagia, and repeated PR bleed for the past 4 months. She had iron deficiency anemia, was had 2 IV iron infusion. She was finally diagnosed with rather advanced chronic adenocarcinoma. As discussed earlier, she was the defaulted surgical follow-up right from beginning, and then in the diagnostic workup, and also default the subsequent oncological follow-up. Now, few lessons. I think iron deficiency is a very common problem. Glanzmann disease is very rare. So sometimes it will be easy to dismiss that, oh, she's carrying an iron deficiency anemia because Glanzmann predisposes her to some bleeding. But so when we look at a patient, we always must try to figure out whether the severity of anemia can be adequately explained by the underlying cause. So I asked my colorectal surgeon, can the PR bleed cause such a severe anemia? His answer is no. More so is after being banded. So I think that's so despite chasing for her, I mean, we all feel very sad for her. But the other thing, just for discussion, is we must have good documentation of the events. I still remember quite vividly, there's a very prominent physician that was put up, found to be, had in the wrong for diagnosing, for missing the colorectal cancer when the patient was treated for iron deficiency anemia. So this is something that if the patient did not avail themselves to investigation, we must document that we did advise, so that that's medically may be important subsequently. Now, few short words about Glanzmann disease. For those who are interested in benign hematology. So this deficiency of platelet membrane 2B and 3A, absent platelet aggregation, and you could get up by the study platelet aggregation test. The aggregation is absent using adrenaline or collagen, but not lysocytine is by a different pathway. So that corrects the aggregation. Is autosomal recessive, and they present with clinically quite moderate to severe bleeding. Some patients can have actually rather severe bleeding. So the diagnosis, the one that gives it away, is a prolonged bleeding time, defective platelet aggregation, the pattern of the aggregation, lack of aggregation. Now, just to highlight, just to add on to iron, IV iron usage, how to select patient for IV iron. I think the first thing is we must make sure the patient has iron deficiency anemia, because we know that sometimes we get some thalassemia patient, we get hypochromic microcytic anemia. In the report, someone will say that this could be iron deficiency, and I think to be fair, sometimes clearly we can't tell the difference. So low serum ferritin is absolute must for my practice. I mean, before I infuse iron to anybody. Now, we must always remind ourselves that good medicine is simple medicine, and simple medicine is minimalistic medicine, in which case we always choose something that's simple. So oral iron should be considered as a first line, unless it's not tolerable, not feasible. Some patients are just not compliant, so it's not feasible, and not effective. For example, patients with chronic inflammatory bowel disease and so forth. So the other thing that's important is in the past medical history, patient had irregular follow-ups, patient who have previous blood transfusion, patient who just cannot follow instruction. Maybe their IV iron has got its merit because at least you solve the problem. Patient who had GI bleed, inflammatory bowel disease a while ago, I mentioned, probably are good candidate for IV iron. Iron deficiency in anemia in pregnancy, well, that is something that's quite effective. I still remember when I was in student, the women in the mid trimester pregnant who are lined up to have IV iron. So I asked the obstetrician, why you do that? Say, oh, if you don't correct now, when it come to the term, we all have a nightmare chasing after blood, chasing after anesthetists, and stressing ourselves. So the ONG guys are quite organized. Um, and patient going for high blood loss surgery, cancer patient with anemia and on erythropoietin also can be considered for IV iron in select normal cases. Now, what are the contraindication for IV iron? I think anyone who had known hypersensitivity to either product or any of the component or perimeter iron. So once you document that the patient is hypersensitive, don't try it again. Now, a known allergen or hypotensive reaction in the past is also taken as a contraindication. So some patients will become hypotensive easily. So maybe not a good candidate to IV iron. Now, this sounds so obvious. Non-iron deficiency anemia. So patient who had thalassemia, patient who had anemia due to any other reason should not get IV iron unless they are short of iron. Patient who are iron overload, all the more reason. It's easy to get iron in, it's very hard to get iron out. Patient who have active systemic infection is thought to not a good idea to get IV iron because iron seems to be a good nutrient for the microbes. And last but not least, don't infuse iron in the first trimester pregnancy. And just a reminder that iron is an essential element for cellular life, but free iron is a source of cellular damage and toxicity. And as I mentioned a while ago, iron overload is a real problem, very expensive to treat and potentially dangerous in the long run. Thank you.
Alan, sorry, Dr. M,
Yes.
what are your thoughts about the first trimester intravenous iron? Why is it contraindicated?
It's always mentioned. I think the rule of the thumb is we never like to give patient even Panadol in the
Yes.
first trimester. I think that might be the main reason. Second reason is you have hypotension and during the if you're unlucky. You see, it's always quoted 1 in 200,000, isn't it?
Yes.
But for the life of me, I never infused 200,000, but I see one or two cases of it, very
It's just
serious,
unlucky.
serious anaphylactic reaction, where patients, not my patient, but I heard story patient end up in ICU and whatnot. So, not something to be taken lightly, though they mentioned 1 in 200,000.
Yeah.
Infusion reaction, maybe to 1%, that kind of thing. But 1 in 200,000 is, I mean, it's rare, but I just don't know, but we do come
I think
across
you just need
cases,
one to spook you actually. It's actually sometimes you felt whether
Yes.
it's necessary or not.
But I think anaphylaxis potentially can be life-threatening. So it's not, we really have to be very conscious about,
Definitely.
Some just this fishbane reaction, a bit of chest tightness,
Yes.
a bit of
Yeah.
but not true
Yeah.
anaphylaxis. But I think
Yes.
the point is that if we give IV iron, we must have the facilities to
Resuscitate.
in case there is a severe anaphylaxis. So
Yeah, because you never know.
we will not be giving it in the setting of a clinic without
Yes.
any equipment.
Preparation,
Yeah, I think it's important.
Okay. You need actually full resuscitation facility like adrenaline and so forth.
Yes, definitely, most definitely.
Yes.
So I'd like to move now to Dr. Allen, who is going to present us with another case, and we'll have some discussion after that.
Thank you, Dr. Harris. Next month, September 22nd, why September 22nd, 22/9 or translocation 9/22 is CML awareness month. So I'm actually jumping the gun here, talking about a patient of mine with rather complicated CML. This is a 66-year-old lady who presented about 6 years ago with very marked leukocytosis and fatigue for a few months. Previous illnesses were diabetes, and hypertension. Her presenting counts were hemoglobin 9 grams per deciliter. It was a normal cytic normochromic anemia. Platelet count of 312 and a white cell count, which was very, very high at 167. The spleen was enlarged about 5 cm. The blood and marrow were consistent with chronic myeloid leukemia in first chronic phase. So we treated her with imatinib mesylate, tyrosine kinase inhibitor, which is one of the frontline drugs for CML these days. After about a year, we changed to Tasigna mainly because of suboptimal response, and also she had a bit of side effects and rashes from the imatinib. The cytogenetic remission was achieved. I mean, she had no more Philadelphia chromosome, but at 1 year, the PCR was 0.2, whereas the optimal target is less than 0.1. Just I didn't measure any iron stores at the beginning because the MCV was normal, but we had a look at the marrow report at 1 year and it showed adequate iron stores. So presumably she wasn't iron deficient then. Just to share with those not so familiar with CML therapy, nowadays we can assess the leukemic burden in a very much deeper version than just looking at hematological remission, which is normalization of the blood counts, cytogenetic remission, which is just normalization of the chromosomes. But now we're in an era of molecular response. Okay? The primary target is major molecular response of 0.1%. And these days, it's possible to discontinue therapy after some time if we can achieve a very deep molecular response. And these are just some guidelines on what is suboptimal response. So at 12 months, the best response is less than 0.1. So more than that would be warning. And if you fail, means you levels goes above 1%. So there are options. Either you want to just continue or increase the dose or switch. But as this patient also had a bit of blood rash, which he wasn't happy about, we decided to switch. The second line, which was Tasigna or nilotinib. Fortunately, she achieved major molecular remission with nilotinib. With that, we started to see the hemoglobin trending down to about 8 grams per deciliter. At that time, I had my blinkers on. I thought, oh, this is due up. So I decided to give her some ESA or erythropoiesis stimulating agent and gave this with some positive response. And she didn't have any requirement for blood transfusions to support her. But in March 22nd, March 2022, the HP started to drop to 6 and she was very giddy. The peripheral blood film actually suggested iron deficiency. Transferrin saturation was only 7%, confirming iron deficiency. Because she was very symptomatic, I had to give some packed cell transfusion. But I wanted to correct the iron deficiency, so I opted for intravenous ferric devisomaltose, which is monofer. And then because I didn't want to have problems with bowel prep, we give oral iron, it's not only slow, but it interferes with bowel prep. But then she refused to get a scope done. In March 2023, the HP started dropping again. She was stable after that, but really started dropping again, and no overt bleeding. She still didn't want a scope. We gave her some ESA injections again, but things came to a head when it dropped to 4.6. The saturation was only 9%. The time we admitted her, we noted she actually did have melena, which she didn't report earlier. So we gave additional red cell transfusion, and this time we gave intravenous iron, ferric carboxymaltose, which is ferring jack, and we scoped her. And this is actually a repeat scope because she's had one in the past. This time there were no significant findings in the stomach and large bowel, but the jejunal scope revealed angiodysplasia. So whereas when she scope previously didn't show anything, this time there was angiodysplasia of the small bowel in the distal duodenum. and proximal jejunum. And that was the site of bleeding. Angiodysplasia of the bowel are actually swollen or enlarged vessels in the bowel which can bleed, and they are more common in the older adults more than 60 years old. The etiology is unknown. Can be diagnosed on endoscopy or video capsule endoscopy or angiography, and the treatment can be medical, surgical, or embolization. In this lady, it was fairly extensive in the small bowel, so we gave her tranexamic acid and the drug of choice for angiodysplasia, which is thalidomide. Since then, this year, her hemoglobin has been more stable. She did have another episode of melena and required a bit of transfusion, but we plan to just monitor counts and iron status. So complicated anemia in CML, we have to, learning point is to think about other factors other than the disease or therapy for CML, which may cause the anemia. The choice of intravenous iron here is that the response, I like it because the response is faster compared to oral iron. And in cases where we want to actually scope the oral iron may interfere with bowel prep. And so IV iron is convenient. Although we gave blood transfusion for this very symptomatic anemia, when there's active bleeding, we should give blood transfusions. But just a reminder that transfusions do not fully correct iron deficiency. There's only about 200 milligrams of iron in each packed cells. So you still need to correct the iron deficiency eventually. So this is just my short case, not so rare and exotic like Dr. Ernst Glansman's disease. I'll be happy to answer any questions. There are already quite a lot of questions lined up in YouTube.
Oh, really? Have you got access?
Just
Yeah.
before we
Yeah,
forget,
any
I
comments?
just want to discuss the point faster response compared to oral iron. I think there have been studies that if you take the oral iron optimally, absorption normal, and you IV iron going in, the rate of anemia correction is the same. But in the case of we may say faster response is actually because we cannot assure the patient takes the oral iron as instructed, and also we cannot be assured of the absorption in some cases, hence the faster response. But if you have an optimal setting whereby the oral iron is taken, absorbed, corrected, and IV iron, you put them side by side, it's exactly the same.
And that's what I always thought.
Yes.
But I've seen now rates of increment 1.5 grams, 2 grams a week, which I never ever seen with oral iron.
But I think it's the IV iron is the optimal setting.
That is true.
Yeah,
That's true. I think, but it'd be very, very hard to take high.
Yes, exactly. That is that. I mean, that's the holding point. But
Because there's a limit on
there's a limit how much they can take. And usually anyone who wants to take oral iron, I always tell them that if I want to start out oral iron, I tell them, are you able to take the oral iron daily for 6 months? Because it take about 6 months.
Yeah.
If they say no, no, maybe 1 month can, then they are more or less candidate. I mean,
I think that's the other advantage of iron compliance after over time.
Yes.
That's always a challenge.
Yes.
Sometimes patient can't come back to us to see us in a follow up, and then lost to because they feel better after the initial iron exposure. So
And then the other point also sometimes when you're not sure whether it's a GI source or blood loss, if you give them oral iron, then not sure whether it's melena or whether it's iron causing black stool.
Correct.
So
I think
there are some pros there, but there are also some cons.
yeah.
because the pros of oral iron, of course, is cheaper. And if you're a very compliant patient, if they want to take oral iron, I say it's fine.
And then they can have the. I think Dr. Allen got plenty of questions lined up.
On YouTube, there are plenty of questions.
Okay.
There's since we preferred Slido, so we'll answer the questions from Slido. And the first question from Slido there is, can we treat with oral iron supplementation based on low serum iron alone? Or must we have low serum ferritin to justify oral supplementation?
I think I'll start. because as I mentioned in my first few slides, something can be misleading because you got this entity where you have pure iron deficiency, and on the other hand, you actually have iron sequestration or functional iron deficiency. The end product is the same. Patient lack iron, and the way that you tackle it is probably about the same. They still need some iron supplementation, but you might actually miss a group of patient where there is a different etiology of their anemia. So even though at the end of the day the patient might respond to the iron that you actually give, but you might not be tackling the underlying problem of the anemia. So that's why ferritin is actually more sensitive in terms of diagnosing the iron deficiency. But as I mentioned earlier on, there's some caveat to it in patient where there is actually a lot of inflammation going on. You might have a transient increase in ferritin level, so you might actually miss it. So one of the other tool that I utilize actually the transferrin saturation level that was demonstrated very well in Dr. Allen's case, where from the two results that were picked up, both actually have transferrin saturation of less than 20%. So if you ask me the most sensitive test, yes, transferrin saturation may be the most sensitive test, but it's not. It may not be readily available. So ferritin is readily available. Turnaround time is faster. So it's a better tool for us to actually use to actually identify the group with iron deficiency. So if you have low serum iron, the patient may have functional iron deficiency rather than absolute iron deficiency. So you might actually miss a few things. I mean, any comments from
Okay. Low iron level does not mean iron deficiency because you really need the TIBC and then calculate the transferrin saturation. You can have low serum iron and the patient is not iron deficient if the TIBC is low, for example, in chronic inflammatory state, chronic, the so-called anemia of chronic disease. So the transferrin saturation will be high even though the serum iron is low. So it's an incomplete test. So we should not treat iron with iron just on serum iron alone.
even though not perfect, but very thin. It's with the availability of transferrin saturation as well. It put you in a better position to make the diagnosis. Dr. Ng, you want to say
Yeah,
something?
I think the historic, there was a time about 10 years ago, we actually want to drop the serum iron test because the test is not very robust. The CB is coefficient variance is varies a lot. That means you do in the morning, afternoon, evening, the serum iron change a lot. Unlike ferritin, which is a very robust, very steady kind of parameter. But it was retained because we want to diagnose hemochromatosis, where you can see transferring fluctuation is abnormal. So, but it remains true that serum ferritin is, I think, is a more robust and steady kind of parameter. Of course, I mean you can do both, but serum ferritin. I mean, if you want one single test, we pick serum ferritin.
Another question there is at what level of hemoglobin for blood transfusion should we administer blood?
I mean, it's an eternal question where everybody has got been asked this, and the thresholds also among us actually different. It actually depends on the symptoms of the patient as well. Some patient with chronic blood loss, they may not need blood transfusion even though the hemoglobin dropped down to 5, while others that's usually running a hemoglobin level of 12, then when they drop to 8, you need to transfuse them straight away. But general rule of thinking is uh, if the hemoglobin is more than 8, usually you can get away without the need for transfusion. If the levels below 8, then it's not wrong for you to consider blood transfusion. If the hemoglobin level is more than 10, more or less, you tend to try to spare the patient from having transfusion if you can help it. But obviously, you look at the circumstances. So the threshold in terms of the level of hemoglobin for you to need transfusion differs from scenario to scenario. We in hematology where sometimes our patient actually been having iron deficiency for not anemia for quite a while. They tolerate it very well. And in this patient, even though the hemoglobin is low, we try to actually correct them by giving iron and or erythropoietin, trying to spare them from having blood transfusion, especially in the group that probably need blood transfusion for a long time.
See, I'm impressed with the up to 80% of inappropriate blood transfusion.
Yes, I was very surprised as well.
Maybe I think that's a bit overrated.
Maybe it probably doesn't count
Yeah,
out because
but
to be
very high, very high. But
right.
I think the level, I think there are a few other, of course, it's very patient dependent. The patient who is having heart disease, patient, the drop is very rapid, like in autoimmune hemolytic anemia, then you may have to transfuse because I have the misfortune of seeing the patient training days who had autoimmune hemolytic anemia, and when the level dropped to about 4 gram or so, she developed heart failure. She developed cardiac arrest and cannot be revived. Patient actually died in front of you because when you have anemia heart, the heart is here all shrunken. You cannot get things working again. So I think the rate of drop of hemoglobin, the underlying condition of patient, how symptomatic the patient, and of course whether patient is hemodynamically unstable. But usually I'm very nervous patient walking around with 6 grams. So my standard joke is, what is your car number plate? Then you mention, doctor, why you want to know? I want to keep away from that car.
If there's any magic number, I think the UK guideline quoted 7. But we've not got away without transfusing. They're very well, very minimal symptoms. I just last week sent home somebody 5.5 grams.
What's the car number?
But she's no symptoms. She's walking around, not really. She was just
I think those with chronic iron deficiency anemia, the body get used to it. They are anemic for the past maybe 4 or 5 years. They're looking at you, why this doctor want to transfuse me, I'm perfectly all right.
I think we take the last question.
There's a whole bunch of questions from John Doe. I'm sorry whether, it's almost 3.
Yeah.
Maybe we have to pick and choose some questions from John Doe in YouTube. Maybe Haris, can you click on? Can you see the comment there?
Oh, yeah.
You choose what you want. You can click and then it may come out of the screen. So, okay.
Specific for CM, your CML case is very popular.
Yeah, maybe some controversy.
I think the one that you could quick you already.
We delve in the comparative effectiveness of various iron formulation in terms of the rapidity of response and sustained benefit for patients with severe iron deficiency.
I think it's a controversial question is because I think at the end of the day,
The response is the same, isn't it?
Yeah.
It's the amount of iron you get.
iron that you get. I think that's the end of the day. Some of them you cannot actually push more than 100 milligram in one session. You can always call the patient back after a few days to do the second dose.
So the differences to me anyway are how much iron can you give? Some formulation you can't give total iron. Some you can. The duration of administration, which may help. Some are very short, some are longer. And then the risk of anaphylaxis also is a bit variable. The one may be very low and some are not so low.
The price.
Yes. And finally,
We don't have to talk about that.
so IV iron is not cheap compared to iron. So we have to weigh all these things.
Because in blood transfusion, especially in the government setting, we do not see the actual cost of each pint of blood. So that's probably why, cost sometimes doesn't enter the discussion when comparing to intravenous iron.
I think the classical indication of IV iron is they cannot tolerate oral. They can't tolerate oral. And then compliance is poor than IV.
Yeah, I think we go by that mantra. I think at the end of the day.
Talking about cost, the previous Minister of Health said that the cost of doing a liver transplant in government is $500.
Oh, that's cost to the patient.
To the patient. So,
There was a question because I mentioned ESA and IV iron in my patient with CML.
Mm.
Actually, I gave ESA because I thought the anemia was due to
Yes.
the tyrosine kinase
Yeah.
inhibitor. I didn't think there was iron deficiency at that time because the MCV was normal until the peripheral blood film later with and the HB drop suggested. So PBF is still very, very important. You need to look into it. And the saturation is low. And then the indication of iron replacement was there. Because she was 66, postmenopausal, the risk of something in the bleeding GI was very high. So I gave IV iron to plan her for a scope. She actually, I didn't mention, she did have one scope, didn't find anything significant first time. Then she bled again. I mean, it dropped again, and this time she had melena. And the scope, this time we went deeper. The gastroenterologist went deeper, found the jejunal angiodysplasia.
I think the take-home message is, I think we probably discussed, I mean, the underlying iron, cause of the iron deficiency is definitely paramount. You need to find out what it is. In terms of treatment, the main indication would be if they can't tolerate iron, oral iron. So the response depends on how much iron you can actually give per session. So I think any parting thoughts from everyone before we close out the session?
Yeah, I think the IV iron is definitely a useful modality of treatment, but we discussed the patient and the patient. I think for some patients, really get them out of the months and years of chronic ill health, the, between oral iron and not taking and taking, the kind of thing. So it's very useful. But having said that, I think I myself I always remind myself that I should not give of IV iron to someone who's potentially iron overload. So must really check, because if iron gets in, then you have big trouble. Yeah. So I think that's the thing. That means I think we have to use it judiciously, but there's certainly groups of patients that will benefit from it. Yeah.
There's a couple of questions. Maybe you got time because you also in the Slido. Is there any? There's a mention about iron deficiency in pregnancy, and is it indicated to give IV iron when there's a reducing trend of serum ferritin with a hemoglobin of 11?
I would have thought that we should try oral iron first. There's definitely a need for iron, iron supplementation. Um, Usually, if they are able to tolerate oral iron, definitely it's something that we should treat. Majority of our patients or pregnant mothers usually will get some degree of supplementation. So if the oral supplementation doesn't seem to be doing the trick, yes, actually there is intravenous iron has a role to play to correcting it because it does actually affect the outcome in certain papers that have come through. But how low is the ferritin level is the other question that we need to ask. I think the threshold from the papers that I've seen is 50. So if it's more than 50, it's okay.
My impression is when women are pregnant, they become more responsive or they listen to the doctors more, and they can bear the hardship. Unlike guys. Yeah. You ask them to swallow a tablet, they will swallow a tablet. You ask them to get classic injection, they will have classic injection. You ask a guy to inject themselves for a week, the tablet will come. So I think probably oral iron, I could say, could get the job done. Not forgetting that during pregnancy, the HB can drop, due to dilution effect.
Physiological anemia HB can be down to 10.
1.5, 2 gram drop is common, yes. Yeah.
So iron supplementation is routine.
Yes.
There may be a role of IV.
Yes.
If they really, really cannot.
Not tolerability, visibility, and of course effectiveness. Yes.
One more question. I think I'm sorry, there's so many in YouTube, but we just don't have time. Is there any treatment for anemia with Southeast Asia myelofibrosis?
So
There's not. No, I mean usually they are mild. Usually these people are mild. They might be half a gram off the mark. So I always quote the example of Pete Sampras. I think most people will remember Pete Sampras is a very famous tennis player. And one day he was playing in Russia and then he fainted. So they discovered that he's got thalassemia trait. So all those thalassemia trait will come and say, hey, doctor, I cannot work. I'm very tired. I said, look at Pete Sampras.
We're still playing very well. Yeah. Okay.
Okay, so we have come to the end of this session. Sorry, there are so many questions, but we will have to actually end it now. So it's time to claim the CPD point. So just a reminder, you can scan with the MMA app. I'm going to show the point in a little while, the QR code in a little while. But if you're watching from a mobile, please take a screenshot and save it to your gallery or album, photo album. And then you open the MMA app, and on the right hand side and at the bottom right, you will see able to select the image from your gallery, and you can scan the image. Okay, the moment everyone is waiting for. Here's the QR code. We check this work. Okay, yeah, excellent. So, yeah. Please don't share. I have to make an appeal because the our as responsibility of CPD providers is to make sure that only those who participate in our sessions do get your point. And there's, like all things in life, we should not take shortcuts and stick to ethics. All right. There are some upcoming changes in the way the eligibility of QR code coming in because of some misuse, unfortunately. So so we hope you enjoyed and learned as we have, even among we talk among ourselves. So wish everybody a happy weekend, and we'll see you in the next grand rounds. So take care, everybody.
Take care, everyone.
Yes, take
Bye-bye.
care. Ask patients, number plate.
Learn that one.